I want to talk today about acute AFib with hemodynamic instability. I want to discuss how to actually manage those patients that we see every single day in the ICU, practically in real life, unlike the theory stated in the guidelines. You will hear this in all guidelines. Hemodynamically unstable AFib requires emergent electrical cardioversion. This is one of the least helpful cliché that is carried in all of medicine and guidelines and textbook. This situation is practically more complex than just cardioversion and is marked by three major practical problems. And I will dissect those problems. One, acute electrical or DC cardioversion is problematic as it requires sedation unless the patient is in extremis and near cardiac arrest. Sedation by itself aggravates hypotension, worsens shock, or converts a pre-shock into full-blown shock. Why? Because sedation has a vasodilatory effect and it has a catecholamine blunting effect. So sedation has a risk. In the process of cardioverting the patient, you may aggravate his situation. In addition, one problem of acute electrical cardioversion is that when there is an active trigger of AFib, such as acute heart failure or acute sepsis, AFib will likely recur immediately or soon after cardioversion. So saying that those patients need emergent electrical cardioversion may signify aggravating their situation temporarily and knowing how to deal with that. And it may mean that, well, it may come right back after you shock him. And we've seen this over and over. It's a very common situation, that immediate recurrence. A second set of major problem with that statement here is, what is unstable AFib? And when is AFib the culprit of the instability? Unstable AFib is defined usually as AFib with hypotension with shock, clinical shock with low perfusion, or massive heart failure, not just pulmonary edema, hypoxemia. It's massive heart failure with massive pulmonary edema, often requiring intubation. And when do we attribute this hemodynamic compromise to AFib? AFib with a rate of 110, 120 is not by itself a cause of hemodynamic compromise. AFib consistently reduces cardiac output at all rates, even when it's rate control, and is an aggravating factor in all heart failure and in all hemodynamic situations, but it's not the cause of a full-blown shock. AFib with a rate over 150 beats per minute is often a major contributor to the shock and is considered for emergent cardioversion. In systolic heart failure, the cutoff for AFib-induced major hemodynamic compromise is likely 120, 130 instead of 150 beats per minute, and I will explain why. Also, in order to attribute hemodynamic compromise to AFib, AFib must be newly diagnosed or newly recurrent, not a known permanent AFib. A patient with a known permanent AFib who comes with shock, don't attribute shock to AFib. He's been living in AFib forever. Why is it causing all of a sudden shock now? So it's not usually a known permanent AFib. I've seen that mistake as well many times. So why does AFib cause hemodynamic compromise at a lower heart rate in heart failure? In heart failure, the heart rate that provides the highest cardiac output in the acutely ill is around hundreds to 110s for decompensated heart failure with reduced EF, and likely 110s to 120s for heart failure with preserved EF. And why is that? We know there is a Bowditch phenomena in normal heart and in the failing heart. Whenever the heart rate increases, the intrinsic contractility increases up to a certain point. This is what we call the Bowditch effect. That certain point is lower in heart failure with reduced EF and is about hundreds to 110s as opposed to a much higher rate in normal individuals. In heart failure with reduced EF, the maximal cardiac output and the maximal contractility seems to be achieved with a heart rate around hundreds to 110s, whether in sinus rhythm or in AFib. And this is based on three Bowditch revisited trials. Beyond this rate, cardiac output often does not rise because of the loss of the Bowditch effect in the energy and metabolically depleted systolic heart failure. Hence, contractility and cardiac output decline at higher rates. And those are the three Bowditch revisited trials. This is the second one of them, and this one showed that the peak contractility is at a heart rate of 103 plus or minus 22 in heart failure versus 120s to 140s in matched older patients. Now, in heart failure with preserved EF, pacing data and a beta blocker withdrawal trial suggest that higher baseline heart rate of 75 to 80 and probably a peak heart rate in the 120s improves quality of life and symptoms compared to a baseline heart rate of 60s. Cardiac output and likely contractility and relaxation, lusitropy, improve up to a heart rate of 110s to 120s in the stiff LV of heart failure with preserved EF. We know that stiff restrictive LV of heart failure with preserved EF needs a higher heart rate to maintain cardiac output. But it's also likely that contractility and lusitropy improve up to a heart rate of 110s, 120s based on multiple studies, but especially that nice in vitro study of the myocardial cells of diastolic heart failure and based on that pacemaker trial. So in sum, to attribute hemodynamic compromise to AFib, the rate must be over 150 in the general patient and over 120 to 130 in systolic heart failure, probably over 130 for heart failure with preserved EF. Now, a third major caveat of saying that unstable AFib needs urgent cardioversion is that there are two types of AFib where hemodynamic compromise does not warrant emergent cardioversion. For example, AFib with borderline blood pressure of 90 to 100 without full-blown shock and without low perfusion state. And the second situation is AFib with a full-blown shock from another cause, for example, clear septic shock or massive bleed with hemorrhagic shock. You may have AFib with a rate of 110, 120, or even 150, but there is a clear cause. And that AFib needs to be rate controlled, but it doesn't need to be cardioverted acutely. It's not a major contributor to that shock. Rate control is enough in those cases. And anyway, acute cardioversion is plagued with the hazard of sedation and the high rate of immediate recurrence of AFib. So we'll aggravate the patient hemodynamic status with cardioversion without benefit and with high immediate recurrence. There are special rate control meds that need to be used in the setting with hemodynamic compromise, and I will explain those. So, in light of the major hazard and poor efficacy of electrical cardioversion, and after carefully knowing when to attribute hemodynamic compromise to AFib, how do we perform cardioversion in those patients? When AFib needs to be cardioverted emergently, consider pharmacological cardioversion and or the safest pharmacological rate control meds with the least hemodynamic effect instead of electrical cardioversion. Electrical cardioversion remains appropriate as per guidelines, particularly in the patient who's in extremis, who's in profound shock, pre-cardiac arrest, who's already obtunded, where you need little to no sedation. But even in that patient where you do electrical cardioversion, it's not going to be enough because there is a high rate of immediate recurrence. So even in that patient where you do electrical cardioversion, you do need to use pharmacological antiarrhythmic drugs to sustain the sinus rhythm. And you need to know that there are 5 options for pharmacological cardioversion in those hemodynamically compromised patients. Number 1, amiodarone. It has an immediate rate controlling effect, but a slower and less effective cardioversion effect at around 8 to 12 hours with about 50% efficacy at 8 to 12 hours. More effectively, it sustains electrical cardioversion if it is eventually needed. And usually we give the bolus 150 milligram over 20 minutes to avoid hypotension. Do not give it in a shorter time frame. Fast bolus will cause hypotension and aggravate shock in this patient. These are some ideas about amiodarone. Amiodarone has a rate controlling effect because it has a sympatolytic effect, which is a downstream effect of the beta-adrenergic pathway, not a direct beta blocker effect. Despite this sympatolytic effect, amiodarone has little to no negative inotropic effect by itself, and it has little risk of hypotension, less than 10%. Therefore, it is well tolerated in heart failure and in those borderline hemodynamics or in shock. The issue is with the IV formulation of amiodarone, which is mixed with excipients that have lipids in them and that have a pronounced vasodilatory effects and some negative inotropic effects, which cause hypotension. This is particularly the case when you quickly administer the IV bolus of amiodarone, and it's reduced when you slowly give that bolus over 20 to 30 minutes. Hypotension is neither seen with oral amiodarone and is not seen with another aqueous IV formulation instead of lipid formulation. Now, the second major option beside IV amiodarone is IV procainamide, which is given as an IV infusion over 30 minutes, 15 milligram per kilogram. It can be used even in heart failure, and it has a 50 to 60% cardioversion rate at 30 to 60 minutes. It's faster than amiodarone. This is based on RAF2 trial. Procainamide is not popular in the US. It is quite popular in Canada, and it is quite effective. And regarding its safety in heart failure, there is another trial that studied procainamide in VT versus amiodarone. It's called the Procamio trial. And actually, procainamide proved effective against VT in patients, most of whom had structural heart disease and an EF that was 40 plus or minus 13%. So most of them had low EF, yet it was effective and safe. And it was actually safer than amiodarone, less hypotension and less pulmonary edema in VT. So by extrapolation, I think IV procainamide is still relatively safe in heart failure. Again, not popular in the US and not a lot of expertise with it in the US. The third option is IV ibutylide, which is a bolus that may be repeated at 10 minutes. Efficacy is around 30% with the first bolus and up to 50% when you give the second bolus 10 minutes later. And it's quickly effective at 10 to 30 minutes. The main risk is torsade de pointe of 3 to 4%, and this is higher in patients with severely reduced EF. Importantly, magnesium 2 gram IV immediately before ibutylide mitigate this risk of torsade de pointe. The fourth option is IV magnesium. This is very important in all acute AFib, whether with hemodynamic compromise or not. It has been shown that IV magnesium improves AFib rate control to less than 100 beats per minute in over 50% of treated patients. It also mitigates the risk of torsade with ibutylide. So magnesium not to cardiovert AFib, but to slow it down and rate control it, which is very important in those hemodynamically compromised patients until they get cardioverted by those drugs or in case they fail to be cardioverted. IV magnesium has been shown beneficial in this meta-analysis, and usually the dose is around 5 grams, 2 grams over 15 minutes, then 3 grams over 3 hours. And actually, magnesium IV is given a class 2A in the ACC guidelines for rate control of acute AFib. A lot of us don't do that, but we need to use more magnesium in acute AFib, not just with hemodynamic compromise. But it only works as adjunct to other drugs, not standalone magnesium therapy. Now, the fifth option is a very interesting option called IV landiolol, which is an ultra-short-acting intravenous, very selective beta-1 blocker. This is very effective for rate control of unstable patients that prove difficult to cardiovert, again, until they get cardioverted by the drugs, or in case we fail cardioverting them, at least we need to achieve good rate control. And IV landiolol achieves this acute rate control with little to no negative inotropic effect and little to no hypotensive effect, even though it is a beta blocker, and I will explain that in a little bit. It's a very new beta blocker. It just got approved by the FDA. It's not yet widely available in the US. So those are the 5 options for the hemodynamically unstable AFib that needs cardioversion. 3 of those options actually achieve cardioversion. The other two achieve rate control while awaiting cardioversion. Now, for AFib associated with borderline blood pressure, not shock, or associated with non-AFib shock, such as AFib at a rate of 120, 140 beats per minute with septic shock, you need to rate control this AFib. You don't need to cardiovert it. But you need to rate control it with safe drugs. And when we say rate control, the target AFib rate is usually less than 100 teens beat per minute in the acutely ill as per ESC. It's a little bit higher than the target in chronic stable atrial fibrillation. The same applies to decompensated heart failure. You don't need to cardiovert AFib with a rate over 120, 130 beats per minute in decompensated heart failure unless there is full-blown cardiogenic shock or massive pulmonary edema. If you have decompensated heart failure with an AFib rate over 120, 130 beats per minute without cardiogenic shock, all you need is rate control acutely. Then you cardiovert later once the patient has been diuresed and has been in a compensated stage a couple of days later. This will make cardioversion more effective, more sustained, and less risky. Sedation will be less risky. And you can perform TEE before cardioversion as well. And here are the 4 options for rate control of AFib with questionable hemodynamics or non-AFib shock. So 5 options in the AFib-induced hemodynamic compromise and 4 options for rate control in questionable hemodynamics. The first option is IV amiodarone, which is usually the top agent. Everybody gets concerned about using IV amiodarone acutely for rate control because there is a concern that amiodarone has the theoretical risk of acutely cardioverting AFib. Indeed, it's an antiarrhythmic drug with some efficacy in acute cardioversion. So there is a concern in acutely cardioverting AFib that doesn't need to be acutely cardioverted in a patient who may have an atrial appendage thrombus. However, here is the thing with amiodarone. The short term, less than 12, 24 hours, likelihood of cardioversion with amiodarone is only slightly higher than that of spontaneous cardioversion. It's only 20-25% higher. For example, when you give amiodarone to those patients, the chance of cardioversion at 8 to 12 hours is 50%. At 24 hours, it's 70 to 80%. But the chance of spontaneous cardioversion is in the 50%. Keep that in mind, especially in those ill patients as you start to control their illness. So true, there is a risk of acute cardioversion with amiodarone, but it's not much higher than the risk of spontaneous cardioversion. And it's a risk that one may need to take the same way you take a risk of acute cardioversion in a patient who is hemodynamically compromised. And here is the data from a recent meta-analysis regarding acute cardioversion rate with various drugs. IV or PO amiodarone, the cardioversion rate at 24 hours is 70 to 80% versus a 50% spontaneously. Procainamide is about 70% at 9 hours. Flecainide and propafenone have the highest cardioversion rate, 80% at 2 to 5 hours. The second option for rate control is IV digoxin, load, usually 500 microgram, first bolus, then 250 in 6 hours, and often another 250 in another 6 hours. The problem with DIG is that it has a slow onset of 1 to 5 hours, and it's not effective in high catecholamine state, critical illness, shock state, where again you have a high catecholamine tone. The third option is, I explained, IV magnesium. The fourth option is IV landiolol. Again, you need to know that option, not widely available in the US yet, and I don't have experience with it, but from what I read about it, it's likely to be a miracle drug in those critically ill patients with AFib. Why? It's an ultra-short acting, super selective beta-1 blocker with a half-life of 4 minutes with limited negative inotrope and hypotensive effects. It may be used in cases of instability or decompensated heart failure with low EF, even lower than 30-40%. Per ESC, it has limited impact on myocardial contractility or blood pressure. And this is more information. Landiolol at a dose of 1 to 10 microgram per kilogram per minute. You start the lower dose and you slowly up titrate it, watching your hemodynamics. The beta 1 to beta 2 effect is 250 to 1, so it's very, very beta 1 selective. And maybe that could explain why it has very limited to no negative inotropic effect, yet it has more pronounced negative chronotropic effect than other beta blockers. So less to no negative inotropic effect, yet more negative chronotropic effect than other beta blockers. And this may be because the beta 2 receptor remains unaffected, so the catecholamines, whether intrinsic or administered catecholamine, continue to act on the beta 2 and continue to provide contractility and inotropism via beta 2 receptor. Multiple studies in septic shock patient and various ICU, medical and surgical ICU patients have shown that landiolol has rare to no hypotensive effect, less than 5% hypotensive effect, no reduction of cardiac output, and actually an increase in stroke volume. It has been commonly used in some of those studies in patients receiving beta agonist or dobutamine at various doses. The latter continue to provide the inotropic effect and the vasoconstrictive effect despite landiolol. So you can use landiolol with catecholamine, norepinephrine, dobutamine. And these are some of the references for landiolol. Now I will move on to discuss an overlapping topic, which is acute symptomatic AFib along with decompensated heart failure. A heart rate of 100 to 110 beats per minute may be helpful, including in the patient with AFib, as it increases cardiac output and LV emptying by increasing the number of cardiac cycles per minute. Cardiac contractility also increases up to a heart rate of hundreds to 100 teens based on the Bowditch effect and the Bowditch revisited trials. Tachycardia over 120 beats per minute is counterproductive and reduces the contractility of the energy-depleted myocardium, the cardiac output, and the peak O2 consumption, particularly in heart failure with reduced EF. Now, tachycardia over 120 to 130 beats per minute with severe hemodynamic compromise often needs acute cardioversion in systolic and probably in diastolic heart failure to improve LV energetics, LV contractility, and LV filling. Now, those who read my book will know that I say that when you have decompensated heart failure, restoring the atrial kick does not improve cardiac output much. And that's true. Look at this figure. When you have compensated heart failure, you have a small E filling in diastole and big A wave filling from the atrial kick. When you're in decompensated heart failure, you have a big E wave and the atrial kick cannot push too much flow because of the high LV diastolic pressure. So really those patients do not benefit a whole lot from the atrial kick, but they do benefit some. So when you're in AFib and you're in decompensated heart failure, restoring sinus rhythm makes you go from this to that. You're not improving LV filling much by restoring the atrial kick. However, when you're in compensated heart failure here and you restore the atrial kick, you're improving cardiac output a lot. You're improving LV filling a lot. You have a huge A wave. And actually restoring sinus rhythm in compensated heart failure dramatically improves symptoms of the patient because of that atrial kick and dramatically reduces the risk of decompensation and improves cardiac output and improves EF and improves mortality in those patients, as has been shown in many trials. That's why we like to cardiovert AFib in heart failure after we've diuresed them and put them in a compensated stage. However, those patients who are in shock along with a rate over 120 to 130 may still derive some benefit from acute cardioversion. Why? One, you do establish some atrial kick, which provides some cardiac output, which is vital in those patients with critically reduced cardiac output. And second, and more importantly, we know that aside from the loss of atrial kick, the irregular heart rate in atrial fibrillation by itself reduces cardiac output by 16%. For the same heart rate, having irregular rate versus a regular rate reduces cardiac output by 16%. So cardioversion not just establishes a small atrial kick, but it regularizes the heart rate, which improves the cardiac output. Also, it slows the heart rate down, which again, in those patients with systolic heart failure and impaired Bowditch phenomena, that improves LV energetics and improves myocardial contractility. So for all those reasons, even though cardioversion is not as effective as in compensated heart failure, it remains effective in the decompensated heart failure with shock for those three reasons I explained: the small atrial kick, the regular heart rate, and improving LV energetics and the Bowditch effect at lower heart rate. In AFib, the irregular heart rate by itself further reduces cardiac output by 16%, aside from the loss of atrial filling. In fact, LV filling and stroke volume sharply and exponentially decrease with a short RR cycle, which is not made up by the longer RR cycle. The very short RR interval, less than 500 milliseconds, reduces stroke volume more than the long RR interval makes up for it. And this is an illustration. This is a regular rate of 90 beats per minute. This is an irregular rate of 90 beats per minute. And this is another irregular rate. The more irregular you are, like here, alternation between very short and very long RR, the more you drop your cardiac output, because you dramatically drop your stroke volume with this, and you don't make up for it with this much longer RR interval, because you're only able to fill during a certain period of that long RR interval, especially in a decompensated heart failure with a narrow E wave. So that's why cardiac output drops on average by 16% with an irregular heart rate, and wedge pressure goes up by 20% based on several landmark studies from the 90s. And when you need urgent cardioversion in acute AFib with decompensated heart failure, you have those same 5 options I discussed earlier: amiodarone, procainamide, ibutylide, magnesium, and landiolol. Landiolol and magnesium mainly to rate control you safely while awaiting cardioversion. Keep in mind that procainamide and ibutylide have higher hazards in heart failure patients. And you have those same 4 rate control options in acute decompensated heart failure with acute AFib. You have the IV amiodarone, IV digoxin, magnesium, and landiolol, which will become very handy once available. And for rate control, when you have that heart rate of over 120 beats per minute without severe hemodynamic compromise, you use rate control to achieve a heart rate less than 100, 110 beats per minute. And you have those same 4 options I discussed before: IV amiodarone, IV digoxin, IV magnesium, and IV landiolol, which will become very handy once widely available in the US. The ESC and ACC guidelines allow in heart failure with preserved EF and even in heart failure with mid-range EF, 41 to 50%, allow the use of beta blocker or diltiazem acutely, beside those options that may also be used in heart failure with preserved or mid-range EF. Now I will finish with a summary idea regarding AFib and heart failure. After you treat heart failure decompensation, and for all the reasons I described earlier, it's important to eventually establish and maintain sinus rhythm in heart failure patients, particularly after acute therapy and after heart failure becomes compensated. This is where you will have a higher chance of sustaining the sinus rhythm and a higher likelihood of benefiting from sinus rhythm, as I have shown in this figure. And that is why trials of AFib ablation in heart failure with reduced EF have consistently shown an EF rise of 10 to 30% after ablation, mainly in persistent AFib, but also in paroxysmal AFib with high burden, even in patients whose AFib is rate controlled. Those 2 trials here have shown a reduction of mortality with AFib ablation, and those 2 here have shown a dramatic improvement of EF with AFib ablation. And this benefit of sinus rhythm likely extrapolates to heart failure with preserved EF. This is based on the Cabana trial of AFib ablation, the heart failure with preserved EF sub-study, which derived a more dramatic benefit than non-heart failure patients. And this is also based on East AFib NET4 trial, heart failure sub-study, where rhythm control, mostly with drugs, improved outcome compared to rate control, more so in the heart failure patient. The absolute benefit was doubled in the heart failure patient. Rhythm control, even with drugs, even in heart failure with preserved EF. But the best data is in heart failure with reduced EF, AFib ablation, but probably benefit also with rhythm control with drugs, probably also in heart failure with preserved EF.